Yeah, we'll start in a minute.
Presentation.
Great. Yep. Hello, everyone. Thank you for joining the session of the Oxygen Therapy and Critical Care series. Before we begin, just a few reminders. We will be using the chat function for question and answer. So if you have a question, please send us it through the chat and feel free to introduce yourself. If you have any IT issues, also send us a message through the chat and we would be pleased to assist you. Today's session is being recorded and your attendance is consent to being recorded. So thank you. So thank you for joining today. We are on session 7. Our topic is defining ARDS. And as usual, our session will be led by Dr. Francois Xavier Uimana from Narugange COVID Referral Center. With us, we also have Liberata, Dr. Joseph, Dr. Venuste, and Dr. Apollinaire, who will be helping us work through the materials today. And so with that, I will pass it on to Dr. Francois Xavier to get us started.
Yeah, thank you, Alana. That's for the time we are now January 19th, not January 12th. We will make some change on this date. Thank you for the introduction for today's session. As you said, it's session 7, talking about defining ARDS. It's an interesting topic today, as we are in the COVID pandemic period. Most or all patients with the COVID-19 developed to the ARDS status. So today we are going to better understanding what is ARDS, how to manage. We can go to the next slide, please. Yeah. The session of today, session 7, defining ARDS. We cannot successfully go through this topic without the support from different partners, including ECHO, Program Assistant National, University of New Mexico, Stanford University, and the Global Anesthesia and Critical Care. Thanks to all of them. And today we are going then to talk about defining ARDS as I introduced with it. So what are you going to discuss? Next, please. As usual, our sessions are case-based discussion from the real scenario we are living with every day in our day practice. We are having Thomas, a 46-year-old male who presented to our COVID center with hypoxemic on respiratory distress. And this patient had been tested the COVID-19 positive 2 days ago, and then is requiring ICU admission for this respiratory failure, intubation, and mechanical ventilation. Vital signs on the admission was heart rate, as you see on the screen. And the respiratory rate was 35, and then the BP was less than 100 of SVP, and the saturation was 90%. After the intubation, the settings on mechanical ventilation has been put on assisted control, volume control, FiO 100%. The respiratory rate equal to the respiratory rate before intubation, tidal volume, and the PEEP on plateau pressure. So today we are going to understand better about ARDS when you intubate a patient with ARDS and which settings you are putting to the patient. Next, please. Next, please. Our learning objective today is to define respiratory failure, understand types of respiratory failure. Again, defining hypoxemia. We had in the previous session understood better what is hypoxemia, but today with respiratory failure, want to understand better what is it. And then we had to understand the 4 key criteria of the definition of ARDS. To say ARDS is not just a saying. You must have evidence based to say ARDS. We are going also to apply the Criteria modification ARDS of ARDS, and then understand the severity of ARDS. What are the pathophysiology in ARDS cases? The principles of lung protective ventilation, as we discussed in the case about mechanical ventilation settings. And also, what are the parameters to help us adjusting and improving oxygenation or ventilation, which is CO2 elimination from the mechanical ventilator. And then what are the appropriate interventions to improve oxygenation in ARDS patient when other measures failed? So then what will be appropriate intervention for improving outcome in ARDS? So with these learning objectives, we want everyone in the session today to master and understanding better when you are receiving a patient in respiratory distress. When do you think about ARDS? What do you have to do to improve his oxygenation? Next, please. To understand better this topic of today, our co-panelists, Dr. Venus, Dr. Joseph, Madame Liberata, and Dr. Aponer will go through the whole topics, including how do we breathe, how define the respiratory failure, chest X-ray interpretation, how do we diagnose hypoxemia either by clinical signs, pulse oximetry, or the blood gas measurement interpretation. Is not just taking a sample. So you have also to interpret. And the key criteria to define or to confirm the ARDS with historical cause of ARDS, since when, and the Berlin definition, the Kigali modification. How do we compare Kigali and the Berlin so we understand better in that context? Then Dr. Joseph will help us to understand the severity cause of ARDS, the pathophysiology, where is very, very important. We will be interested in that. How do you treat in general when you have a case in ARDS? And we will understand better the goals and the parameters we have to set on the mechanical ventilation once a patient in ARDS has been intubated. And we end up with Dr. Apollinaire discussing what are the lung protective ventilation in ARDS, what are the benefits, advantages, and understand when the patient is still not making good oxygenation, what do you have to do? And then when still having poor ventilation, what do you have to do? So in such case of ARDS and respiratory failure, what can we do better, or which intervention can we do to improve oxygenation beside those interventions of mechanical ventilation? So with this, I think the picture we're having here will understand better the ARDS and what is it, management, definition, and then we help our patients to improve from the respiratory failure, ARDS, from either infection, from either sepsis, from either COVID-19 we are facing today. So the floor, I'm going to pass it to Dr. Venus, who is going to help us. How do we get oxygen, the blood, how do we breathe, and then the respiratory failure, and what can we do from the chest X-ray? Ms. Venus, welcome to the panel.
Thank you very much, Dr. Xavier, for the nice introduction. It's a pleasure to share with you this interesting topic today. So welcome to everyone who is in the attendance. So I'm going to talk on how do we breathe and why do we need to breathe. So to breathe, or breathing is moving in oxygen and moving out CO2 or carbon dioxide. And to have this function accomplished, we need a fully functional respiratory system, which is composed of upper airways from nose oropharynx, trachea, to deep from the main bronchus to bronchi, to bronchioles, and to alveoli. And at the level of alveoli, we have connecting the capillary and the functional unit of the respiratory system is this alveolar capillary membrane, where we have the gas exchange, the CO2 from the tissues, which will be released from blood going to the alveoli, then expelled out, and the oxygen will enter to the lungs and diffuse from this alveolar capillary membrane, going to the blood and circulates to tissues to have the cellular function, which is the generation of the energy to support the whole human body. So next slide, please. So from the previous session, we have seen the tissue oxygenation, how we define the hypoxia, which is low oxygen content at the level of the tissues. So we have seen 4 different types of hypoxia. One which is hypoxemic hypoxia. The other second, which is anemic or hyperemic hypoxia. We have stagnant hypoxia and also histotoxic hypoxia. The hypoxemic hypoxia is the most common form of hypoxia, and generally it happens with high altitude. When the altitude increases, the partial pressure of oxygen decreases and your lungs won't be able to effectively transfer oxygen from the ambient air to the blood. The anemic or hyperemic hypoxia is when you have the reduced ability of blood to carry oxygen. And these are conditions which affects the hemoglobin, like anemia, hemorrhage, and hemoglobin disorders, but also carbon monoxide when there is like poisoning by carbon monoxide, it will bind to hemoglobin, and oxygen can't be fixed and carried through the circulation. So the stagnant hypoxia, this one occurs at the circulatory level in a patient who has a compromised blood flow, like in a shock, either cardiogenic or neurogenic shock. But also another example is exposure to cold temperatures, where extremities will get necrosed because of impaired blood flow to the extremities. The histotoxic one occurs at the tissue levels where the cells get oxygen, but they are unable to use that oxygen. So, you know, the oxygen is carried in the blood by hemoglobin, and it enters to the body at the level of the alveolar capillary membrane as a functional unit of the respiration, as I've said. Next slide, please. Next slide. Yes. So this busy graph or slide is to show you the cellular respiration. What do we need? Normally, we have two types of cellular respiration. We have aerobic and anaerobic respiration. The aerobic respiration, which is the one suitable for human, it has 4 steps. The first step being glycolysis, where the glucose is degraded and to give pyruvate. And this first stage occurs outside the mitochondria. It occurs in the cytoplasm of the cell, and it gives the glucose is broken to pyruvate, and it also creates ATP molecules as the energy storage form for the cells. So the second stage for aerobic respiration, this one occurs at the level of the mitochondria, and the pyruvate which was generated from glycolysis, it will be used to create the acetyl coenzyme A and the carbon dioxide. And after this, it comes the third stage, which is the main stage of the aerobic respiration, which creates more energy. It is called the Krebs cycle or citric acid cycle, which is a series of chemical reactions happening in the mitochondria. And this one will create the acetyl coenzyme A will be used to create more nicotinamide acid dinucleotide and hydrogen, as well as the flavin adenine dinucleotide plus hydrogen, but also carbon dioxide and additional ATP molecules. And after this third stage, there will be a like what we can call terminal stage or final stage, which where we have the nicotinamide acid adenine dinucleotide and flavin adenine dinucleotide, hydrogen plus oxygen. They will be used to create massive amounts of ATP molecules through electron transfer in these molecules. And this stage also will create water molecules. So as a takeaway in general, this aerobic respiration, it's to transform the food which is in the form of glucose into the energy within the cells. And we have also the anaerobic respiration, which doesn't use the oxygen to generate the ATP molecules. So this anaerobic respiration can happen in human, like in the skeletal muscles for athletes when they get strenuous exercise. The oxygen shortage, when it happens, the glucose is metabolized into lactate and ATP molecules. And this lactate builds up in those skeletal muscles, and the person can no longer be able to exercise. So as you can see, it's in the anaerobic respiration is not suitable for humans. That's why in this session, we are trying to see how you can improve oxygenation or deliver oxygen to tissues for this aerobic respiration to happen, to sustain the life. Next slide, please. So the tissue oxygenation and the hypoxia we have seen at the level of the mitochondria, which is the energy station for the cells where the ATP molecules are generated, and we have seen the role of oxygen in the body. It's to support the cellular respiration and converting the glucose into energy in the form of ATP. So we have the sugar, which is glucose, the plus oxygen metabolized into ATP plus CO2 and water vapor as at the level of the cell. Next slide, please. So the acute respiratory acute respiratory failure, the definition it's defined as the loss of ability to ventilate adequately or provide sufficient oxygen to the blood and systemic organs to support the metabolism. So when this happens, the pulmonary system is no longer able to meet the metabolic demands of the body to respect to the oxygenation of the blood and eliminate the CO2. Next slide, please. So, as in the previous session, we have seen like a kind of recall. We have four types of acute respiratory failure, and one is hypoxemic respiratory failure. And this hypoxemic respiratory failure usually is seen in patients with acute pulmonary edema or acute lung injury, and these disorders interferes with lung ability to oxygenate blood as it flows through the pulmonary vasculature. Like in the case described in the introduction, that patient likely has hypoxemic respiratory failure. We have also hypercapnic respiratory failure, and this hypercapnic respiratory failure or ventilatory respiratory failure, we have partial pressure of CO2 greater than 50 millimeters of mercury, and it is usually seen in a patient with increased work of breathing due to airflow limitation or obstruction and or decreased respiratory system compliance. So the examples here we have like COPD, asthma, or a patient who is suffocating, but also patients with decreased respiratory muscle power, like people with neuromuscular disease, like Guillain-Barré syndrome or any motor neuron disease. They don't have ability to move in the air and move out the air. Their muscles are weak, and the CO2 will build up. And when you take the blood gases, the partial pressure of carbon dioxide is more than 50 millimeters of mercury. So type 3, which is perioperative respiratory failure, as you see perioperative, they are due to either effect of anesthesia, but also the surgery itself. And the patients are not able to, they have reduced, kind of reduced residual capacity, and they have atelectasis, and this atelectasis will be the one causing respiratory failure. So type 4 respiratory failure, it's, or you can call it respiratory failure due to shock or hypoperfusion of the respiratory muscles. This can happen either from shock or lactic acidosis, but also anemia can lead to this type of respiratory failure. Next slide, please. So you can have like globally two types of respiratory failure if you try to summarize the respiratory failure. One may be from lung failure at the level of the functional unit, which is the alveolar capillary membrane. Like in case of ARDS, as we'll see in the session, when the oxygen or CO2 can't diffuse at this membrane, you have a respiratory failure. But you can also have respiratory failure from a pump failure or a ventilatory failure, which is manifested by hypercarbia, either from central cause or mechanical cause or fatigue. Next slide, please. So Coming to the chest X-ray interpretation in the setting of acute respiratory distress syndrome. So we haven't yet defined it. It will be defined by the next presenter. So the acute respiratory distress syndrome, which is a form of acute lung injury, the severe form of acute lung injury, it has to be defined with the 4 key criteria we will see, but one of the 4 key criteria is the radiographical findings, which is a diffuse or bilateral alveolar infiltrates that are seen on chest X-ray. And the alveolar infiltrates are from the proteinaceous influx of fluids in the alveoli or interstitial space. This will be highlighted further in the pathophysiology or pathobiology of ARDS by the next presenters. Next slide, please. We have in the first we have two normal chest X-rays where you can see that the rank parenchyma are normal, the costophrenic angles are sharp, and you don't have any cardiomegaly. On the other side, on chest X-ray edge, you have a patient with ARDS showing bilateral infiltrates, and you have a blunted right costophrenic angle, which is suggestive for pleural effusion. And on B, you have as well the chest X-ray for a similar patient, but it shows persistent bilateral infiltrates after 7 days with some degrees of improvement. So in short, the one key component of criteria for ARDS is this bilateral alveolar infiltrates or feature of pulmonary edema, but they can't be explained by a cardiogenic shock or volume overload. So in emergency settings, some doctors try to give diuretics, and diuretics will improve the pulmonary edema or the radiological findings from volume overload or cardiogenic shock. But for ARDS, diuretics won't improve these radiological findings. They might persist from days to weeks. So next slide, please. So in summary, before I conclude this presentation, or my first part presentation, the ARDS resulting from the lung damage as a result of leakage of fluid into the alveoli and interstitium, it will lead to an appearance of pulmonary edema, which is non-cardiogenic in origin. And as you can see, these alveolar infiltrates, they are not specific for ARDS only. Any patient who has like a pulmonary hemorrhage, they can present in a similar way, or a patient who received a blood transfusion and develops lung injury from the transfusion, they can as well present a similar feature. That's why you will need other criteria to confirm its ARDS. So the bilateral opacities on chest imaging, which can't be explained by other pulmonary pathologies like pulmonary nodules or pleural effusions. So the imaging for ARDS, they are variable depending on the stage or the clinical course of the disease, but generally the radiological features start to develop after 24 hours from the initial insult to the lung. So I think this is the end of my presentation. I can take a few questions, like 2 or 3 questions, if there are any, or any comment. Thank you very much.
Yeah, thank you, Dr. Vedus, for the good presentation. For the audience, it's your time for clarifications. With Dr. Venus, we had to know how to breathe and what is the importance of oxygen in the blood. So in case of respiratory failure, when you don't have oxygen in the blood, your cells will work in anaerobic milieu, and then you will lead to the lactic acid, and your cells will not work properly. So really, people with respiratory failure, please take care of them. Give them oxygen so that they can make good work from the oxygen, into their cells. Acute respiratory failure, there are 4 types, as we discussed, but commonly they have in common to have this type 1 and type 2. Type 1, you have failure to oxygenation. Type 2, you have failure to ventilation, as we said. And the chest X-ray in this kind of ARDS will help you to differentiate them with the chest X-ray from the cardiogenic pathology. So if there is no question, I'm trying to invite Madame Liberata so that she helps her to understand what is really ARDS Dr. Venus come to talk about in short, and then we understand better what is the importance of things to have to do in our daily practice in a clinical scenario we are meeting. So, Madame Liberata, people can write into the chat, and then you can start to help us understanding what is ARDS we are talking today. Thank you.
Thank you so much, Dr. Best. Can you hear me well? Can you hear me well?
Yes, we hear you. We hear you.
Can you hear me?
Yes.
Thank you so much. Thank you so much, Dr. Best, for the presentation. It's good the background of what I'm going to discuss now, and to offer and discuss what is ARDS and when it was started to be defined. We want to know how to diagnose a hypoxemia, because ARDS, as we all know, it can help us to save lives and detect bleedings from semi-compliance. For diagnosing hypoxemia, the first thing that we can do with our own eyes without any lab investigation or any tool is to use our own eyes and look at our patients to take any clinical sign which can relate to hypoxemia that the patient is presenting. First one is bluish, and I'm very sure that somewhere most of us have seen such kind of
Hi, Liberata. You're a little hard to hear right now. Would you mind maybe logging out and logging back in? Because the sound is not clear.
You're not hearing me? Sure. Can you hear me now?
That's a little better. And Dr. Venust, there's also a question in the chat about hemothorax. It says hemothorax also shown a result of CXR. Looks like ARDS or pulmonary edema.
Yes, I've seen the question. Thank you, Felix, for the nice question. So sorry if I have said it was hemothorax. So the X-ray displayed or shown it was a case of ARDS with small pleural effusion on the right side. So the hemothorax on the X-rays, it will give homogeneous opacification to the level it is reaching. So it won't be the same as ARDS or pulmonary edema. For the ARDS or pulmonary edema, you have this alveolar infiltrates, or there is this deposition of proteinaceous fluid into the alveolar and interstitium, which will give bilateral infiltrates in the lungs. I don't know if it's clarified. Felix, did I respond to your question, please?
Can I move
Hello.
on? Can you hear me now? Yes.
I think I'm hearing you well.
Okay, thank you so much. Maybe the one who asked a question was different. I was talking about how to diagnose hypoxia, and one thing that we can do is use our eyes and see if there is any change to our clients as early as we can. I've been saying that maybe more of us will see someone with a bluish color on the extremities, and sometimes when the hypoxia is very severe, it can be central and the blue color is found on the tongue. You find patients that was talking, she's now confused, the level of consciousness is decreasing, she looks so tired, she's trying to compensate with increasing the heart rate and increasing the rapid breathing. Heart rate and rapid breathing, those are the vital things that we frequently do for our patients. Let's use them properly and see how we can save our patients by early detection of hypoxemia, considering clinical signs. The next way of diagnosing is to use a oximeter. Can you go to the next slide, please? Next slide, please.
Sure, Liberata, it's a little hard to hear you.
Can you hear me?
That's a little
Can we
better.
move next slide?
Okay.
It's a bit better.
Yes, I think it's a little bit better.
Can we move to the next slide? Yes, thank you.
Yes, yes.
Can we move?
We are on. We are.
Thank you so much. The next way of diagnosing hypoxemia is to use the oximeter. That's I hope that have all most of our things. Using the oximeter, you will detect if a patient is doing hypoxemic or not. You remember how we interpreted? We say that the literature has different say that the normal oxygen saturation we find with our oximeter should range between 95 to 100. And it's between 90 to 95. Just ask a glucose monitor to see what might cause this oxygen decrease. So
Liberata.
I think, Liberata, your sound is unclear. So
Yes.
maybe if you can log out and log back in, and maybe Dr. Francois, are you able to cover her?
Yes. Yeah, while she's arranging the issue, we can intervene for her. So
Can you hear me? Can you hear me?
there are still some
Can
echoes
you
in
hear
your.
me, Francois?
We are still having some echoes in your voice. Roberta, allow me to take over, please, while you are trying to correct the problem. Roberta?
Okay. Thank you. Thank you. Thank you.
Thank you. Thank you. I think people hear me well, better without echoes. It's running today here in Rwanda. So sorry for the voice of running. So as Liberata was introducing, diagnosing hypoxemia is coming from the introduction discussed before with Dr. Venus. How do we get oxygen in our blood? So how do we know that a patient in respiratory failure is hypoxic? There is 3 ways. One way is clinical signs. Other is pulse oximetry. We discussed a lot in the previous sessions. I will not go everything. And then the blood gas analysis, which is very invasive, and not all health facilities have the capacity to take these blood gases. But the health facility where they have this capacity to do blood gases, you will be able to know the pressure of oxygen, the partial pressure of oxygen in the blood. And also you can know if there is CO2 retention, and then you may know the type of respiratory failure you are having from one of the 2 we discussed, failure to oxygenate and failure to ventilate with it. And the pH has to be in low when you are having acidity from the blood gas. With the 3 things you have to understand, or you can know that the respiratory failure patient is hypoxemic or not. Next, please. There is this historical course of ARDS. We are not going into details, but what you have to know that this concept of acute respiratory distress syndrome is not a disease, actually, is a syndrome, has been introduced into 1967. And with this concept of ARDS in 1967, people had the confusion, how do we know this syndrome better? And then the meeting of Berlin in 2012 had to elaborate the criteria to know what exactly. I hope people, you hear me good, you hear me better.
Sure.
Yes, very
Okay.
clear.
Thank you very much. Also, this will answer to the question of Jean Felix in the previous chart, that not every chest X-ray with bilateral infiltrate is an ARDS, and not all ARDS are treated by fluorescence, as people may say. So when you are having such chest X-ray in front of you, you have to differentiate whether is ARDS or non-ARDS bilateral infiltrate based on these 4 criteria. Criteria 1, you have to know the timing of that injury, of that lung injury. The timing here is when we have this respiratory failure and this chest alveolar damage we are saying on chest X-ray has been developed within 1 week, meaning within 7 days. So within these 7 days of clinical insult is the time where you can start saying that you are having ARDS. That is in terms of timing. Within 7 days. After that, we may talk about other things. Second criteria, we have to understand oxygenation level. Reason why in the previous talk we discussed about hypoxemia. How do we know the oxygenation level here? We must know the pressure, partial pressure, oxygen in the blood, and the FiO2 the patient in the respiratory failure is requiring. Please remember that the FiO2 is from room air is 21%, as we said. As you increase using the oxygenation delivery devices, as we discussed the previous, so you may know what you are working on. And when you do this blood gas, you may have this partial, the partial oxygen in the blood, and you can calculate this PF ratio to define and clarify ARDS as one of the criteria in the Berlin definition. So when you calculate this PF ratio, you must know the severity level of the ARDS you are having. I'm emphasizing on this as we are fighting ARDS COVID-19, so that people have to know when to talk about ARDS and which category you are having. The third criteria is this alveolar overload, or fluid overload in the alveoli. The respiratory failure should not be fully explained by the cardiac failure. When we say this lung edema should be explained without the cardiac intervention. If there is heart failure, we are not talking of ARDS, but we are talking about the flash pulmonary edema, and we treat according to the protocol in place. The fourth criteria, you must have a chest imaging. To talk about ARDS, these four criteria has to be met, and this chest imaging or chest X-ray should have bilateral infiltrate or bilateral opacities, which are not effusion or atelectasis or nodules, so that the effusion also may show or may look like you are having ARDS. So when I'm talking about ARDS, and ARDS as it is very, very, very serious condition, a serious syndrome, don't miss it, but also don't overdiagnose it. Then in 2016, here in Rwanda, Kigali, I remember I was in my residency. We discussed about no ability to have the blood gas machine. So how will we have this criteria number 2? Oxygenation requirements, and then people discuss how we can have Kigali modification of the Berlin definition by excluding this partial oxygen in the blood by using this invasive blood gas machine. So then it comes the discussion of having the Kigali modification of the Berlin, which we will have in the next. Next, please. Next. So as I was saying, commenting about the Kigali modification 2016, the proposal was like from the to Rwanda definition. As you see, for the main definition, we must have a mechanical ventilator. We must have the blood gas machine to have this, the partial arterial oxygen in the blood. And also we must have a PEEP. In Rwanda, not all hospitals have such requirement to meet ARDS definition according to Berlin. And from then we say that how can we, without this blood gas machine, have the comparison which is corresponding to pressure of oxygen in the blood, which we took like a saturation, oxygen saturation in the blood, which is non-invasive, oximetry here. Secondary, with not all the patients here in Rwanda have that chance to be on the machine, but may have the ARDS. How can we detect them earlier as we can, so that without a PEEP, how can we define ARDS? That is the reason behind of Kigali modification of the Berlin definition. We will see the comparison, how they differ, how they complete each other. Next, please. So the Kigali modification of the Berlin definition provides a mechanism of identifying ARDS in all areas of the world, including resource-constrained settings, is what I was commenting. And the reliable estimation of PF ratio from SF ratio can be accomplished. Is here where I was saying when you don't have blood gas machine, you can use this pulse oximetry and the ratio is the same. The lung ultrasound, which is being included in the bedside, now we are having what we call point of care ultrasound, and also may replace the chest X-ray, which is not always available as the portable chest X-ray machine in all wards in patients. So with ultrasound, you may know the bilateral filtered by using the ultrasound, so that from those advanced equipment in the Western to resource constrained settings, including Rwanda and Africa in general, we can also not miss ARDS of our patients. Next, please. This is the ARDS modification by Kigali. As I said, the 4 criteria are the same in all definition as in all criteria. So the timing is still the same, within 1 week of clinical insult, or a new or worsening respiratory symptom. This means you are having already an injury, but you are having worsening respiratory symptom, as when a COVID case comes to you saying, I have been tested positive like 2 weeks ago, but like 3 days ago, I started having this symptom. So try to see if you can classify him in ARDS case. And after that, you will know how the severe the ARDS has. As I said, for oxygenation case, we are not using the pressure arterial, partial arterial oxygen in the blood, because we are in the poor settings where we don't having blood gas machine. And I think 80% of the audience here, they don't know, or they don't know that machine of blood gas, or they never seen where to do the blood gas, or by chance, if they saw them, is not the routine practice in our health facilities. So with a pulse oximetry, now you are having saturation, which you can compare to FiO2 you are delivering. Please remember, on room air we have how much, on nasal prongs we are having how much, you estimate how much, on facial mask you're estimating how much, etc., etc. And by those devices of oxygenation, you can know which the PF here in Kigali modification, which is the SF ratio you can consider. So the same for the PEEP requirement in this kind of oxygenation, we are not requiring it, as most of our patients in our setting are not having that chance to get to be intubated. You remember, you colleagues, you know, and where you are, how many people you can intubate, and if you intubate them, where are you going to put them on which machine? So you need to come to Kigali, either Sehashka, Faisal, or Kanombe. Otherwise, you are not having the chance to have a people to a patient. This is why with the Kigali modification, we can include most or more patients with ARDS without missing them, and then manage them according to what we will see in the next in the management of ARDS. The imaging is the same, and edema is also the same. Just here, no PEEP, no blood gas consideration in Kigali modification. Next, please. So this is the same as what I was saying about. And by this Berlin or Kigali comparisons, one in the common is 4 criteria are the same. 4 criteria: timing, oxygenation, chest imaging, and pulmonary edema or origin of edema. For Berlin, as I said, they are using, for timing is 1 week. For Kigali is the same 1 week. But for oxygenation, where Berlin, they are using pressure arterial oxygen in the blood compared to FiO2, which we are not having 100% in all settings. In Kigali, we are using pulse oximetry. For oxygenation again, where in Berlin, they are using PEEP consideration. In Rwanda, on Kigali modification, we are not requiring that people, as I explained more in the previous talk, just as I am saying why and the reason. Next, please. So there is some exercises we can make from to the audience, everyone here present who is attending this session. We just give here an example of what is PF ratio maybe to your setting you will say what is SCA ratio. The most important thing here, you have to know the pressure arterial oxygen you are having in the blood. If you have that, the blood gas machine. If you don't have it, you will consider the oxygen saturation in the blood by the pulse oximetry, and your FiO2 is the same consideration, and you will divide them, and then you will have that ratio. The normal ratio has to be, normal one has to be, the good one, the normal has to be more than 500, but from 300 to above, it's also considered as normal, but you are on the borderline when you are in the 300s of millimeter of mercury here. So that if you calculate, you have a patient in front of you, try to calculate this PF ratio, you will know the severity of the case you are having, oxygen requirement you will need, and then from here, if in the audience there is any question, comment for clarification, please. The question is welcome. If you don't have a question, me, I have a question, you calculate yourself. So I'm having a patient, 2 years old, admitted 5 days ago in respiratory failure. Today's blood gas showed that the blood gas showed that is having the pressure arterial, the partial arterial oxygen. It was 42 molecular of the partial oxygen here, and the patient is on high flow FiO2. I don't know, but is on non-rebreather mask 15 liters. Blood gas, I'm having 42 oxygen, but is on the facial mask with reservoir at 15 liters. So the reservoir 15 liters, let us assume the maximum FiO2 of 90%. What is the PF ratio of my patient? Which category of severity this patient is classified in? Please, while you are calculating it, Dr. Joseph is going to help us understand what I'm asking you, and then you will tell me in the chat and the category of that patient after you calculate it. Thank you and welcome, Dr. Joseph, to introduce us more into the classification of the ARDS. Thank you.
So thank you, everyone. I hope you are hearing me very well. Am I right?
Yes, very clear.
Okay, thank you. So let's start on ARDS severity as a part of my presentation. Of course, on introduction, actually everyone knows, we know each other actually. I'm Joseph, I'm seeing Mr. Shibe as emergency physician. So according to the Bailey definition, the ARDS is classified as mid, moderate, and severe. And as Savio said before, this one is done by using the arterial pressure of oxygen over FiO2. It means this oxygen PF ratio will guide us to classify our ARDS. Next slide. So let's go through this table of ARDS. As the previous slide, Xavier said, in the timing, the ARDS all time, there's an acute onset within 1 week of a known clinical insult, means a clinical injury or a new worsening respiratory symptom. And then when you go into to define your hypoxemia, remember the last presentation you had. So when you are the oxygen PF ratio is between 201 to 300, that will be a mild ARDS. So when this ratio will be below 200, so this ratio, this ARDS will be moderate. And when the ratio is below 100, really it will be a severe case. So remember, I said before, the normal oration is between 300 and 500. So in the case of mild ARDS, so the PEEP will be moderate and moderate. The patient will need the PEEP above 5. And in the case of severe ARDS, you need high PEEP, which is above 10. So really the origin of edema in the case of ARDS, really, in the case of respiratory failure, which is associated to a non-risk factor or not fully explained cardiac failure or fluid overload, really there's a need of or objective assessment for cardiac failure or fluid overload if no risk factor are present. So in the case of radiological investigation, so really be in the mild and moderate ARDS, we found the bilateral opacities, and in the case of severe, the opacity will increase up to 3 quadrants of your chest. And of course, in the case of additional physiologically, in the mild and moderate, really, there are no more additional physiological change. But in the case of severe ARDS, the collected body surface really will be more than 10 liters. So it will require more than 10 liters per minute. Next slide. So to see really the pathophysiology of this one. So next slide. Okay, so really, let's go into the literature of ARDS, especially pathophysiology. Of course, after an injury or primary illness, there is inflammatory alveolar injury, which will occur in three sequence. So the first one will be exudative phase, really where we get a damage of alveolar and vascular epithelium. And this one will lead to leakage of water, protein, and inflammatory cells into interstitium. So the second phase, it will be a proliferative phase, where it will be a destruction of immune cell mediated in the alveolar barrier cells. And the last phase will be the fibrotic phase, where we found really a cellular content will float in interstitium. So continue the next slide. So really those three phases are really crucial in case of ARDS physiology. As I said before, this is to summarize those three phases. So the first one, this is A. This A is showing us a normal alveolus. And this is the second one. You see some LED colors on B. This is an exudative phase, where, as we said, the injured epithelial cell will be present. And this is C, the below on the left. It's a proliferative phase, where we see a recovery of the permeability in the cell's barrier. Of course, the surfactant will reproduce again. And using the last one, they see the fibrotic phase, really, you see how the capillary and the interstitial tissues are fibrotic. So next slide. So this is the same like we said before. As I said, a normal alveolus. And then at normal alveolus, of course, it's normal as we go in our anatomy and physiology. So in the case of exudative phase, as I say, we found at a level the interstitium, we got interstitial fluid coagulation. So this exudative phase where there'll be a leakage of water, protein, and inflammatory cells. While at a level of precapillary, it will be an endothelial barrier destruction, then neutrophil will migrate, and there'll be an intravascular coagulation, to be a blockage. So in the case of proliferative phase, as you said, there'll be a destruction of the immune cells mediated. So at the level of the capillary, we see the endothelial proliferation. So and at the level of the interstitium, we found the proliferation of interstitial fibroblasts, which will end by creating a fibrotic tissues in the case of fibrotic phase. Even the capillary endothelium, as we said, the cellular content will flood into interstitium cells. So then the next slide, and we see the histopathological stages. Next slide. Okay. So this is a cause, histopathological cause of ARDS. As we said, there are 3 phases, and the first one, the exudative phase, which will last 1 to 7 days. And the latent phase, it occurs in the first 24 hours. At this level, chest X-ray will be normal, and there will follow a rapid deterioration from 24 hours up to 72 hours. Also, we found a bilateral and symmetric opacities on a chest X-ray. So in this second phase, proliferative phase or intermediate phase, it will occur at day 8 to day 14. And really those radiological change in the first phase will remain, and it will be a diffuse coarse opacities, which might be seen on a chest X-ray image. So it means irreversible fibrosis. So go on the next slide to see the last phase, the fibrotic phase. So next, in the case of fibrotic or red phase, which will occur after 2 weeks, it means after 15 days. If the patient survived the acute phase of ARDS, it means the first 2 phases. Really, radiographic abnormalities will begin to resolve in this latent phase. Of course, the recovery period, so it's a variable, and it will depend on the patient condition, of course, especially his comorbidities. Next slide. Okay, so this is a general management of the ARDS patient. Really, this is a very, very interesting slide for everyone here. So I tried to summarize this management into 3 groups. So the first one, it's a supportive management. So in this supportive management, the patient will benefit from nutrition, DVT prophylaxis, early mobilization, analgesia, and a slight sedation for the patient comfort. So the second group will be a specific management. So where, of course, we will investigate, including X-ray, ultrasound, the CT scan, and the labs and the others, and then we had a therapy, a specific therapy for ARDS. So here we will emphasize on the ventilation, of course, fluid balance management, neuromuscular blockade, of course, pronal position, you remember well, as we told before. Of course, if possible, in settings, the patient should be transferred for ECMO center. So, you know, in Rwanda, we don't have ECMO center. So the ECMO machine, it means a extracorporeal membrane oxygenation. Really, it's a machine which is working in similarity with the heart-lung pass. So, of course, the third group of management really is to investigate and treat underlying cause. So you can't treat a patient and hope to get a full recovery without treating the underlying cause. So the next slide, please. So let's talk about the goals of essential parameter of mechanical ventilator in ARDS. And here we will start by seeing really those normal values of our ventilators. So I hope here everyone know what is a ventilator machine. So when we say a respiratory rate, because it's a number of breaths delivered by the ventilator per minute. So usually the normal parameter on our ventilator is between 4 to 20 breaths per minute. Of course, the tidal volume, which is the volume of gas delivered during in each ventilation, each ventilator mode. And usually the normal one is between 5 to 15 ml per kg on our vent. So, the fractional inspired oxygen, this is FiO2. Everyone is familiar with it. This is the amount of oxygen delivered by a ventilator to the patient. So, is ranging between 21 to 100%. So, when you say inspiratory to expiratory ratio, and you say IE ratio, so this is a rate of inspiration compared to rate of expiration. So here I will bring attention to everyone. Most of people, when we say IE ratio is 2 or is 3, so people are saying it's a second. That's not true. This is a rate of inspiration when compared to rate of expiration. It means here the unit is inspiration, and then the expiration, it will be a kind of a unit multiplication. So usually we can get 1 to 1, 1 to 2, 1 to 3, 1 to 4, 1 to. So it will depend. It will depend on the patient condition. So when we say the pressure limit, is this the maximum amount of pressure the ventilator can use to deliver a breath. So normally our ventilator are ranging between 10 to 20. So let's see the next slide. See the next slide, then we continue with the goal of essential parameter of mechanical ventilator. So this really is in case of ARDS. So ARDS, the tidal volume, the normal values is between 4 to 6 in case of ARDS. So the airway pressure should be set below 30 centimeters of water. Of course, the respiratory rate should be below 35. Then you monitor your minute ventilation, of course, with permissive hypercapnia, in order to get a pH around 7.2, 7.3. So, of course, the PEEP, this is a PEEP, positive end expiratory pressure, will be adjusted and titrated ready to maximize oxygen delivery, not to increase SpO2. So the PIP really, it reflects the resistance and compliance. So if this pressure, expiratory pressure is going above 40, really, it should be a big concern. So the driving pressure, really it will be a good predictor of mortality than a compliance. And this driving pressure should be calculated. This is a formula where we will take your plateau pressure minus your PEEP, and you will get the values of your driving pressure. So we will see in the next slide really what this driving pressure. It's a good indicator, good predictor of mortality. So when your PEEP is not changing and your plateau pressure is increasing, of course you see your plateau pressure, your driving pressure also will increase. This really will be the mortality really will be estimated high. So in the case of both plateau pressure and PEEP are increased, really your driving pressure will be the same. Really, about the mortality will not change. So, but if the plateau pressure is not changing, but the PEEP requirement is changing, really, your driving pressure will be very low and failing. Really, here you can't estimate mortality. Let's go on next slide. So we are still on the goal parameter of mechanical ventilation. So here is to help us how we can set like a kind of basic ventilator settings on a patient with ARDS. So here we put a patient on a volume assist control, and then you will set your tidal volume at 6 mL per kg. Then you set your plateau pressure below 30. Of course, your respiratory rate in that range to 6 to 35. And your IE ratio will ranging between 1:1 to 1:3. And then your target of oxygenation, it will be to get a arterial pressure of oxygen between 7.3 to 10.7. To get an SpO2, which is ranging between 88 to 95. So then here you will set your PEEP and FiO2 according to patient need. So here I remember everyone here that really the target of ventilation. So really it's a two or three components. So the first one is the oxygenation. To improve the patient oxygenation, you need the PEEP and FiO2. Those are going to increase the patient oxygenation. And for ventilation, to ventilate your patient, you will work on respiratory rate and your tidal volume. So and then you will need your patient comfort, where you set your pressure. So at this level, I'm done with my presentation. If someone is having a comment or question, please welcome. Thank you.
Thank you very much, Joseph. There is a question
Yes.
I put there, and I'm waiting for people to, after your presentation, and give us an answer about this. And thank you to the audience that Dr. Joseph comes to tell us about the ARDS, and we understood now the 4 criteria which will help us to understand the ARDS from other clinical differentials. And also the general management of ARDS, the table, the slide you saw, that is very important. And everything we do, it will be based on that. And then after you understand that management, the important role of the mechanical ventilator, but not only the machine, but also having some knowledge about the important parameters on that mechanical ventilator will be setting in order to help your patient, as we found in the with the first presenter. The body without oxygen will be working in anaerobic, and then we read to lactic acid, and our patients will not survive. So that there is many measures to help our patients having oxygen in their blood with this mechanical ventilator. Be familiar with these basic parameters. From that basic parameters, so let us, Dr. Aponer, helps us to understand more about the treatments in details. So we had definition, we understood what is ARDS. Now we are having ARDS in front of us. So how do we help these ARDS patients? How do we treat the patient? Dr. Poner is going to help us treating such patients. Welcome, Dr. Poner.
Thank you, all of you. Thank you for good presentation on the ARDS. Can you hear me? Can you hear me? Hello?
Yes, we can hear
sure.
you.
We hear you, hear you.
Okay, thank you. I would like to thank previous presenters about ARDS. ARDS is not something which is easy to understand, but with these teachings, we'll be learning about it. Can you come with the next slide? Next slide. Okay, in the treatment of ARDS, there is what would be repeating PEEP, as we said, tidal volume, FiO2. Those things will help us to reduce the mortality. And then in the treatment, we will not be treating only ARDS as consequences of body reaction. Will be also treating the cause. It's why, as our patient is having respiratory failure, we put him or her on the ventilator, and then we treat the disease. If the disease is cured, then he will come up with good result of oxygenation. Next slide. Okay. The lung protective ventilation strategies in ARDS, as you can see, this image, it reflects what we have been looking or what is happening in our. You know that in the case of ARDS, our alveoli is somehow inflamed, or there is too much secretion in the alveoli that will lead to ineffective oxygenation. As long as our patient will be on the machine, we will be looking on lung compliance, which is the ability to expand and to stretch so that the volume or the area of gas exchange may be increased, which will be done with our PEEP. Given the tidal volume, the low tidal volume will help us to make our patient to be secured and not to fight with the ventilator. We improve our oxygenation by working on PEEP and the FiO2, which is our target will be to have partial pressure of 55, more than 55, or a SpO2 of 88%. As you saw in the Berlin or Kigali modified ARDS, you saw that because our settings, we don't have blood gas machine to measure this partial pressure, but we can have SpO2 machine to measure our saturation. Also, our FiO2 have to be around 60%. You know that too much oxygen will lead to more lung injuries. Not only will be treating this, or we will not be working on oxygenation only, we'll be having other adjuvant therapy, as we'll be looking like vasomotors, medication to repair lung tissues because they are damaged by the diseases or inflammatory makers. And then we'll be also treating the cause of that ARDS. If it's due to COVID, like giving medication to stop replication or to stop inflammatory markers, storms, that will help our patient to recover and get a good oxygenation, and we win from the ventilator. Next slide. Okay, on treatment changing ARDS, our patient may be having rapid respiratory rate because the characteristic of respiratory failure may be shown by rapid respiratory rate. For example, if someone was breathing at 50 respiratory per minute, that's high. And then if on the ventilator, the patient is still discomfort with that respiration, it will change and the patient will be discomfort. It's why our patient will be need a sedation or parenting. When you are increasing the PEEP, you are increasing intrathoracic pressure, which can cause hemodynamic instability because while increasing intrathoracic pressure, you will be making our heart to be stacked so that there is not enough room of our heart to expand for all movement of the heart. We'll set our tidal volume as you saw, as low, and we increase our PEEP so that the PEEP will be helping to open wide our alveoli. And at that time, we'll not need a high tidal volume. As you saw, the tidal volume is the volume necessary for a breath. If we increase our tidal volume, there will be like over distension, and consequences we can make pneumothorax due to barotrauma or trauma from our machine to our patient. Next slide. As we have been seeing from the publication done or research done on the ARDS and the ventilation, there is an article from New England Journal of Medicine where they were having ventilation with lower tidal volume as compared with the traditional tidal volume for acute lung injury and the acute respiratory distress syndrome patient. Next slide. The clinical value of low tidal volume ventilation was clear demonstrated in the ARDS net study where they did this study. Next. While setting our ventilator in ARDS according to ARDS net, we calculate predictive body weight of the patient. If you are a male, it's 50 plus 2.3 of the height in inches minus 60. For the female, it's 45.5 plus 2.3 18 inches minus 60. After calculating predicted body weight, because of the ventilator, we ask you that predicted body weight. After setting that one, you select ventilator mode. As you have been seeing, you may set with the assisted control or SIMOV. It depends on what. After setting the ventilator, you set ventilator settings initially by tidal volume. Per kilo, but that kilo is predicted body weight. And then you reduce your tidal volume by 1 ml per kilo at interval of 2 hours until the tidal volume is at 6 ml per kilo. After that, you set initial rate according to approximate baseline minute ventilation for a patient, and then you don't go above 35 breath per minute on your machine. You adjust tidal volume in the respiratory rate to achieve pH and the plateau pressure goals. You know that we set those settings to achieve a good tidal volume, to achieve a good pH of our blood, and then a good plateau pressure of our patient. Next slide. Okay, our oxygenation goals, as we said, the partial pressure of oxygen, it's between 55 to 80 millimeters of mercury. If you are using SpO2, the target will be 88 to 95. Then use a minimal PEEP, and you consider increment of FiO2 and the PEEP in the combination, as will be seen, because you can't increase FiO2 only without also increasing the PEEP. As we saw, our lungs or our alveoli are looked as collapsed, and the PEEP will be increasing the exchange surface, and the FiO2, which is minimal, will help us to give a good outcome. Next slide to see the combination of FiO2 and the PEEP. If we are setting, we start by low FiO2 and the low PEEP, and then we increase. If you are at FiO2 of 30%, we'll be having a PEEP of 5. If the target is of arterial oxygenation is not, or SpO2 is not achieved, we'll be increasing FiO2 up to 40, and we keep PEEP up to 5. If the oxygenation is not improved, we'll increase the PEEP, and then we keep the same FiO2. As you can see on the table, till achieving oxygenation of 100% FiO2 and the PEEP of 20. You know that our machine, most of our machine can have a PEEP up to 24, meaning that if you can't increase PEEP without also increasing the FiO2, or increasing FiO2 without increasing PEEP will not show us if we are achieving our goal. Next slide. Okay, as I said, our patient may be fighting with ventilator. If he's fighting with ventilator, he needs a good sedation. If he cannot tolerate with sedation, we paralyze our patient so that to see if we can improve oxygenation. The neuromuscular blockage agents have shown that they improve mechanical viscoelasticity properties of the chest wall. And those medication also, there is evolution in spontaneous ventilator activity by increasing thoraco-pulmonary compliance due to better adaptation of ventilator in the reduction in the expiratory muscle activity. As you have paralyzed all muscles, the ventilator will be, the compliance of our lungs will be in the maximum. And then with that, we'll have, we will be in control of all parameters we are setting in the machine towards the patient. The next slide. We can't say patient in ARDS without saying about how the fluid can be managed. You know, in ARDS, there is a pulmonary edema, which related to increased vascular permeability, but also the quantity depends on the hydrostatic pressure. As you have pulmonary edema, it will increase ARDS, meaning that while giving fluid to the patient with ARDS, you have to think about how those fluid will be eliminated. Next slide. There is a study which have been done to compare the fluid management strategy in ARDS. Next slide. The patient who are not overloaded and the conservative strategy approach may be beneficial, meaning that our patient will be giving a low volume of fluid compared to conservative strategy, which was to give fluid according to maintenance scale we used to have. Next. Next again. In the fluid management, it's important to know our patient, they may be in shock. And then if we find that they are not in shock, if they are not in shock and we see that they are fluid overloaded, we can give diuretics. Dialysis was contraindicated to the study because the dialysis may be someone who is fluid overload. Dialysis was sometimes was indicated, but in this study it was contraindicated. The average time to study was 43 hours. And the study found no difference between prevalence of shock or need for renal replacement therapy once randomized. In the patient who was given fluid, no, the patient was fluid, conservative fluid, there is no difference. Next slide. Also, we saw that prone position may improve our patients who are in ARDS. The mechanism how the prone position is helping to increase our oxygenation. There is a more homogeneous pressure gradient in the ventrodorsal and the cephalocaudal plans. As you know, the physiology of our lungs say that our lungs, the posterior part is bigger than anterior part. This means that if you expose more the posterior part, which is big, and it will help. Also, it will help in the Vicky mismatch. As you know, if someone is in ventrodorsal position, there will be a good the secretion will be out, and they will increase the oxygenation. Next slide. Also, it has shown that it improves bronchial drainage, as I said, and it improves aerosol deliveries, meaning that oxygenation will be good than in the case of prone position. And the abdomen, our abdomen is unsupported, which will lead to a good compliance of our lungs. Next slide. Next. Okay, the prone position efficacy, there is a two primary outcomes that have been studied are oxygenation and the mortality. The oxygenation originally reported to improve in the case studies in the 70s. The prospective study have now shown that prone position will increase oxygenation in 60 to 80% of patients. In the patients who are with ARDS, you see that that's a good number, which can help to reduce the mortality. And some will remain improved oxygenation even after return to spine. Our patient, if they are not comfortable in the prone position because cannot be in that position for a long time, if he's returning in his spine position, he will keep a good oxygenation. Next. We are going to look for 5 steps in proning our patient in prone position. First of all, to prepare preparation of the patient, the staff, because only one nurse or only one doctor cannot put the patient in prone position. Horizontal movement on the sideways, lateral rotation to the side, and the complete proning. And after there is a post-proning installation. The IT may play the video for prone position so that everyone can learn how the prone position is done. Alana, can you play the video?
I think consideration of the time, we can visit the video into our running resource center. Everyone has the accessibility. It's a video showing how do we do the proning position. And I think it's very interesting to everyone here in the audience. So you can keep continuing while people are invited to visit the link. Thank you.
Okay. Thank you, Xavier. Next slide. As we said, while treating ARDS, because it has changed the physiology of our bronchus, of our alveoli, the study has shown that pulmonary vasodilators in ARDS may be used to improve oxygenation in the patient with severe ARDS who are in respiratory or other therapies. As we saw, while treating the patient with the oxygen, but there is adjuvant therapy like those pulmonary vasodilators, which can help to improve our patient vasodilation and the Vicky matching and ameliorate pulmonary hypertension. We have some example as nitric oxide, prostacyclin, and the prostaglandin A1. Those are like a pulmonary vasodilators, can help our patients in ARDS to improve their oxygenation. Next slide. Okay, as a conclusion, in a strategy to manage or to treat our patient in ARDS, the low tidal volume ventilation is good to help our patient to be comfortable on the ventilator and to reduce the effect of that that volume to the lungs, as long as we have increased the PEEP and sometimes FiO2. Best PEEP curve titration, as we saw, how we titrate our FiO2 with the PEEP also will make our patient comfortable. Also, prone position is good to help us to manage our patient. We saw that bronchodilators like nitric oxygen nitric to help us as a bronchodilator. Our patients have to be sedated and be paralyzed if necessary. Steroid also may help as adjuvant medication to reduce the inflammatory process in our lungs. As you know, everything, all we do can have a complication, whether to have overdistension, whether to have barotrauma, whether to have hemodynamic instability due to high PEEP. And while treating that, also we have to treat the cause of that we have caused the ARDS. Next slide. There is like a summary of how to manage ARDS, which summarizes what we have seen. When you have or suspect someone with acute respiratory distress, we have to define which type of one, if mild, severe, or moderate. If severe, you see, there is the initial phase where we focus on lung protection and then protective mechanical ventilation by reducing tidal volume, plateau pressure, and the PEEP. We give sedation, we give neuromuscular blocking agent, and we change position. This, they can improve, the target of those things is to improve oxygenation. Beta phase after 24 to 96 hours, you can start, if your patient has good oxygenation, we can start spontaneous breathing. For mild ARDS, there is what we have to do. Focus on spontaneous breathing in 24 to 96 hours. Then you go to the late phase of severe and moderate ARDS, where you have the mild sedation and you keep spontaneous breathing. And then your target is to reduce the pressure, support ventilation, and up to weaning the patient. I think that's the end of my presentation. Dr. Xavier may keep the presentation.
Yeah, thank you, doctor, for the good presentation about the management of ARDS. And I think in the audience, everyone now is able to define ARDS and is able to differentiate ARDS from chest X-ray from other lung pathologies, and now how to manage the ARDS. Next, please. So
before going,
yes, Joseph.
There is a question which was asked by you. So
Okay.
the patient who was in distress was living in a partial pressure of 40 on mask reservoir. For sure, this patient is dangerous. So really, to calculate a PF ratio of patient who is on oxygen, not on vent. So the first of all, we assume this patient is on room air. It means in this, the patient will have 20% initially. And then this supplement oxygen, this is 15 liter per minute. So when the patient is in oxygen, we assume even one supplemental liter will add 4%. So literature say 4 to 5%. Shall I say 4% of FiO2? So this patient is on 15 liters. So it means they're getting a supplementary FiO2 of around 60%. So if we add the 20 81%.
We are still hearing you.
Okay. So and then the
So
FiO2.
Dr. Joseph was explaining that our 15 liters per minute on an rebreather mask is estimated around of room air, so it's around 80%. So that was an example to calculate the case. So if you take that 40 of PaO2 we calculated, so you may have the PF ratio on that patient. Thanks, Joseph, for your intervention. Let us, as we are working over time, we just have 2-3 minutes. I appreciate the presenters and I appreciate the content presented today, and also the audience. We had to be in the 40s of participants. I hope audience who is here, who is claiming for certificate and CPD credit, things are being worked on, and I think Alana and the other IT partners are working on that. Everyone who is attending any session is getting a certificate, but by rules, whoever attend 3 out of 4 sessions in the part is getting a certificate with a clear CPD. So there are different certificates we are providing in our hub. So this is the second part of our session, our 12th session. Actually, our second part is talking about critical care, as we started from 5, 6, and now we are 7. Next time we will be on 8th session, so that this will make one part and we will provide certificate with CPD credits. But for each single session and your participation, each single session you will get your certificate for that participation. So it's not every single session we are providing certificate. It's just after the part of the level we are seeing who met the criteria of getting the certificate, and whoever get like 1 out of 4, we see how we give him or her the certificate of participation of attendance in one of the 4 sessions in which we are providing the certificate with the CPD. Just here is to make clear things. So after this topic, we are going to have the next session on session 8 on January. Actually, it's not January, as we started with the error in typing of time. We will meet again February 2nd, and we will be discussing about high flow oxygen therapy. And with this high flow oxygen therapy, I think with this COVID-19, people are talking of oxygen therapy in terms which are confusing. We will understand better when you say our patient is on high flow, what do you mean? And what is really different from the science and what you are reporting when you are saying high flow oxygen therapy. So we are still inviting you to come in mass to understand better the oxygen therapy. As every one of you knows, this oxygen therapy is crucial with this pandemic immersion, as we realized it. Today we discussed the ARDS. Everyone is familiar with it, how we manage it. And the people has mechanical ventilation, mostly people who is with us, with our team, with the panelists, with mechanical ventilator, ARDS, FiO2 people adjustments, please refer to our presentation and try to help better the patient presented to your clinic. Thanks to everyone, and I hope to meet with you on 2nd February. But before closing, I could inviting the Assistant International and IT team or other partners. If there is any other addition, please welcome your comment. Thank you.
Thank you, Dr. Francois. Thank you, everyone, for participating today. As Dr. Francois said, thank you to everyone who called in. Thank you to Dr. Francois for leading us through, and to all of the panelists for teaching the material so well. Thank you to Dr. Anna Maria Crawford from Stanford University for creating this program, and to Project Echo and Echo India for making it possible. As Dr. Francois said, there was a mistake on the screen before. The next session is on February 2nd, so in 2 weeks. So please save the date, and we hope to see you then. Goodbye.